Yeah, thank you. Good evening, everyone. We welcome you to this episode of teaching for the FNB students all across India. Today, we're fortunate to have Dr. Hemant Wakankar, a renowned hip and knee replacement surgeon from Dinanath Mangeshkar Hospital. Has been practicing for more than 20 years. And he's going to talk about management of bone defects on both femoral and tibial side in knee replacements, both primary and revision. And so we can keep asking the questions through the chat box. And I will request Dr. Wakankar to deliver his talk. Thank you for sparing time for this educational event, Dr. Wakankar.
Lovely. Thank you very much. I'm going to be covering management of bone loss in both primary and revision. Obviously, the two drastic pictures you see here are, the cases that needed revision, but we'll start with the primary as well. So let me start my presentation here. See, I think we have to really consider what are the bone loss management options. And also have to, just one second, I may have opened the wrong presentation, I think. Just one second. Because that is not the presentation that just one second. I probably opened, I'm going to stop sharing.
Yeah, sir.
I have opened certainly a wrong presentation, surely, because this is the old presentation. Yeah, that's the correct one. Sorry about that. So I'm not sharing the screen as of now, I think. Are you seeing my screen? No.
No, doctor.
Okay, just in a second. Yeah, there we go. You seeing my screen now?
Yes, sir.
Yes.
Yeah, the trouble is you've given so many talks before, and this talk was almost 10 years back, that one that opened. Obviously, this is the updated one. Right, so management of bone loss. What is the issue with bone loss per se? If you see the top picture here, top picture is when you are in a primary knee, when it's all pristine, it's all healthy cancerous bone staring at you for you to cement the prosthesis in, to get good in a bone cement interface. And when you come down to the revision scenarios, as you can see in the bottom two pictures, you can have variety of defects, massive defects, either in the primary scenario on the left or in the revision scenario on the right. And both these situations present really huge challenges. And let's consider what are the things you can do in such scenarios. So in primary knee, you have the advantage that you have a lot of resected bone available to you that you can use as a graft. In revisions, you obviously have to search or look at your options of either procuring allografts if you don't have those available in your institute, or using some metal substitutes. I'll discuss those later on. So in primary knee, I think it's bone defects usually are a consequence of delayed presentation. Most of them are associated with massive deformities. And simply, if you consider a varus knee, you can see the kind of knees that one may get in the practice. You can see variety of defects that you can encounter. And every one of these knees is a unique knee. All of them are varus knees, and every one of them requires individual solutions. So let's see what one can do. I mean, in a valgus deformity, similarly, you may have defects on the femoral and tibial side as well. Most of the times, valgus defects end up, being deficient on the femoral side. But even on the tibial side, I'll show you some examples of defects on the tibial side as well. So what are the options that you have for bone defect? If it's a small defect up to about 10 millimeters, you can simply use cement in the defect, and you maybe use a screw as, a reinforcement for that cement. Or if it is more than 10 millimeters, you may have to use an augment, which is a metallic augment, either in the form of a wedge or a block, or you can use bone graft that is available to you. A reduction osteotomy that is commonly done, especially for varus knees, certainly reduces the size of the tibial defect on the medial side. And that is typically useful in getting the medial balance as well. So as you can see, the reduction osteotomy would reduce the amount of tibial defect that one is finally left with, left to deal with. I'm going to show you some examples of big defects and a variety of different kinds of defects you can see. As you can see here on exposure, the defect is primarily on the anterior and medial side, which is a quite unusual kind of a defect. This is after the tibial resection is done. A tibial resected bone itself is placed back on, and that is fixed with 2 screws, and that is refashioned to flush with the cut surface, and then finally you implant the prosthesis. And this is a 3-year follow-up of the same patient that, whenever you have a defect that is you think is significant. Now, my rule of thumb is if the defect involves more than 1/3 of the medial or lateral tibial plateau, I would add a stem on it. And as you can see here, post-op X-ray and X-ray 3 years down the line, addition of a stem down in the medullary canal that is snugly fitting actually reduces a lot of stress at the level of the joint line. Even the graft, tends to be more secure, and there's less chances of failure of that graft. So this is my rule of thumb. If I have a defect that is involving more than 1/3 of that tibial plateau, either medial or lateral, then I would use a stem added onto the tibial base plate. Now, if you have, how does one assess whether one needs to add? If it's a smaller defect, simple trick is to actually get the leg through the range of motion in using a trial component, trial prosthesis. And during prosthesis, you can observe what is happening to the tibial base plate. If it's tipping into the defect, then you need to add a tibial stem. It's a simple rule of thumb. More massive radical kind of a defect on the entire medial tibial plateau is missing and deficient. As you can see, after the tibial cut has been done, you can see big defect. Now, one has to drill multiple drill holes in the sclerotic bone there and then put a graft on top of that. And again, add a stem. I've used an offset stem here. I've downsized the tibial base plate. I've lateralized the tibial base plate. And I have put this graft here, which is fixed by 2 screws. And this is the X-ray again a few years down the line. And that shows very good incorporation. And the stem, I think, is extremely crucial in such scenarios where there is a really massive defect. Show you an example of on the lateral side in a valgus knee. As you can see here, there is going to be a defect both on the tibial and femoral side. And this is the kind of defect that was there. And I'm just fashioning this defect in the posterior lateral tibial plateau. Again, putting in fixing the graft here using the resected tibial plateau itself, fixing with 2 screws, and that is with the final component in. And that is the post-operative X-ray of the same patient. And this is basically fixed in using 2 screws. And this is again just a posterior stabilized knee. No additional constraint was required here in spite of the massive valgus deformity. And that is the post-operative X-ray of the same patient. Now, some more dramatic kind of defects one may encounter in one's practice. If you see here carefully on the lateral X-ray, that is the kind of tibial plateau one has. So the defect that is there is mostly posterior on the tibial side. And significant defect obviously would require a possible use of a constrained knee if need be, but definitely needs a stem. So again, just on exposure kind of defect that one is seen. This is the tibial plateau that is seen, a massive sloping defect posteriorly. And this is after I placed my tibial cutting jig. And that is the kind of bone that was resected from the tibial plateau. And that is a defect that one is left. And I put this trial base plate, and you can see the amount of defects. Obviously, that needs to be built up and will need support intramedullary. So I prepared the tibial base plate. This is the same tibial base plate I have put on the defect side and held temporarily with 2 K-wires. Again, cut it flush with the cut tibial plateau and fixing with 2 screws going from back to front. And that is the post-operative X-ray of the same patient. And I think this kind of structure works very well, especially when one adds a stem. So stem has to be added for significant defects. So these are just the 2 examples, 3 examples I've shown. One is varus, one is valgus, one is the posterior kind of unusual kind of a defect. One may have variety of other defects as well, and each defect has to be dealt with individually. One has to fashion the graft and put it in the screen. Important thing to realize is this screw should not be touching the metal base plate at all. Remember, these screws are stainless steel screws. The base plate here is titanium. And dissimilar metals should never come in contact because they cause galvanic corrosion. So the screw should never be touching the metal plate, the metal base plate. And that is true anywhere that you use where, dissimilar metals should never come in contact with each other. So that is to do with the primary. Now, I'll just deal with the revisions. The bone loss is probably the biggest challenge in revision knee arthroplasty. Absolutely no question about that. One needs to understand the classifications on both tibial and femoral sides. Both are actually quite logical. There's a classification by Anderson Institute of Research Institute, ARAI classification. And this basically it shows that one is just a minimal kind of bone loss at the level of the process itself. Second, grade 2 is metaphyseal defect, and third is when diaphysis is involved. Same thing on the tibial side as well. So let's consider the principles of dealing with bone loss, especially when it comes to revision. I think it's important that one has to reduce the stress at the level of joint, because the bone at the level of the joint is quite deficient. One has to add an intramedullary stem, and the stem either has to be well-fitting, uncemented, or a cemented stem. One has to try and, I actually personally try and avoid the fully cemented stems, because for any reason, if you need to do a revision, that's going to be a problem trying to take that stem out. So I try to avoid the fully cemented stems, except in special situations. I'll discuss that in a few minutes. One should hope that the trial process actually rests on the host bone, because if it is not resting on host bone, it is a big defect on both medial and lateral sides. Then you may have trouble. You may actually have to use metallic augments that would possibly rest on the host bone. The level of the constraint is finally going to be decided by the state of the soft tissues. And soft tissues, I mean by soft tissues is actually the collateral ligaments and even the posterior soft tissues. So what are the options here that one is talking about? If you don't have allografts available for revision surgery, one has to use wedges or augmentation blocks. And if you have allografts available, you may use them as bone grafts. The principle is to bypass the defect, and for bypassing the defect, there are various bone substitution options that are available in metals, especially the trabecular metal cones, or you can use the wedges that is within the medullary canal. So major bone loss, I think the biggest challenge here is availability of the bone. And bone bank, having a bone bank in your own institute is pretty helpful. Ideally, one should have a sterile, fresh frozen bone that is already been, checked for transmissible diseases, and they have been stored for adequate period of time to reduce the allogenicity. And these ideally are stored at minus 70 degrees centigrade. And most institutes tend to preserve their own femoral heads that are procured from the patients of neck femur fractures. If it is structural allografts, you may have to, get them from certain places. For example, Tata may be able to provide some. Many of the grafts that are available commercially are actually irradiated and freeze-dried. The problem with irradiated grafts is that they don't have the structural integrity, and that can, mean a problem. I think it's better that the grafts are fresh frozen rather than irradiated. Just show you some examples now. Here is a patient of unicompartmental arthroplasty that has failed bilaterally. Both sides were done. Both sides developed a collapse of the tibial base plate. And as you can see, massive defects on the medial side. Now, one can consider this as even a primary scenario, because there is going to be a lot of bone going to be available when it comes to revising, especially when you're going to resect the lateral tibial plateau and lateral femoral condyle. So just show you examples of that. This is the right side that we are operating now. This is on removal of the components. You can see massive bone defects on femoral and tibial sides. And this is after putting the trial component with the stem in. You can see the massive defect that one is going to be left with. This is almost 3 centimeter depth of the defects. And all the grafts that are available, all the condyles were put together and placed one on top of another and fixed with transfixing screw across. And even in spite of that, you needed to use augmentation block. And that is the post-operative X-ray of the same patient. As you can see that graft and the augmentation block have been used, and because the stem is added on, the graft is quite secure. And again here, because it was a revision from a uni, I did not need to use any increased constraints in the prosthesis. So just show you some more examples of the revisions. Here's a patient who has come in for revision of RPF, and you can see that the medial femoral side is, and this actually was an infected knee. So I had to revise all the components and put a cemented cement spacer in. And second stage, one comes around to revising it. You can see the kind of bone defect one is left with. And on the femoral side, the lateral condyle is deficient, and this is the trial components in with trial augmentation blocks on the distal side and the posterior side of the lateral condyle. And this is the trial prosthesis that is showing you the 10 millimeter augmentation block that is placed on the lateral side, 5 millimeters on the medial side, and similar blocks on the posterior condyles as well. Now, important to appreciate that the thickness of the posterior condylar augment would determine the rotation of the femoral component. Now, you know that you should have a good external rotation of the femoral component. Femoral component should never be in internal rotation, otherwise the patellar tracking is going to go haywire. So it's important to understand that posterior augments will determine the rotation of the prosthesis. And that's the final prosthesis that is, showing the actual final augments in place before cementation. And that is a post-operative X-ray of the same patient. And this is the LCCK, that is the constrained prosthesis that has been used. Some more examples. Now, this is a patient coming in for gross polywear and loosening, and you can appreciate the porosis that is there in the distal femur and proximal tibia. And it appears, just by a cursory look, it appears that there might be reasonable bone stock left behind. But remember that bone defects that one is left behind after all the components are taken out are usually massive. And the quality of bone is usually very poor. And one should never underestimate the bone defect that one is going to be encountering in such a patient. This is on exposure, as you can see, after both the components are taken out and the cement is about to be removed. The massive, is the ice cream cone on the femoral side. There are no condyles left on the femur. And tibial side is not so bad, but femoral side, certainly there's no bone left here. And here I have used a femoral head that was, refashioned into a condyle, and they have been, both the condyles have been reconstructed using the allograft, fresh frozen allograft, and both the condyles were reconstructed. And in such scenario, one needs to have a good metaphyseal cemented, at least, if not fully cemented, because your bone at the level of the joint itself is not going to be very strong. And one has to really have a good cementation of the stem. Similar patient here, as you can see, you can appreciate the metaphyseal side on the femur, which is showing massive lytic lesions. And one can really expect that one is not going to have much bone left in the distal femur. And such scenario, again, as you can see, after removal of everything, virtually no bone on the distal femur, except for small shells of epicondyles on both sides. And you can see that trial component placed in and big defects that need to be catered to. Now here I've used a femoral head that I split into two. Again, put on the two condyles and fix them with screws from within. And that is then I have cemented the prosthesis on top. And that is a post-operative X-ray of the same patient. And because obviously the soft tissues were deficient, I've used a constrained knee. So this is the way one can reconstruct the bone defects using allografts. If you have the available, it's wonderful to use allografts. Now, if you have complete loss of epicondyles, where you have collateral ligament insufficiency and severe bone loss, one has to use increasing constraint. And most of the times one has to use hinge prosthesis. One can reconstruct, condyle like I have shown here. I've used a plate from the outer side to reconstruct these condyles, but I have used a rotating hinge here because virtually there are no collateral ligament support at all. So I have fully cemented the stem and used a rotating hinge prosthesis on top here. So the choice is between using a constrained knee like LCCK or TC3 or a rotating hinge or similar hinge as you can see on the outer side. And my my decision is based on the quality of the collateral ligaments that one is leaving behind. If one has reasonable soft tissues, one can use a LCCK or a TC3. Otherwise, one has to use a hinge prosthesis. I'll just show you one dramatic patient. This patient was a rheumatoid patient of mine, in bed for almost 2 to 3 years, big flexion deformity. I did this primary knee for this patient, was quite happy with the final outcome that I had on surgery, at the end of surgery. And when we made the patient to stand up on her own 2 feet, she just crushed her distal femur with her own weight. And this is what happened at 48 hours. And unfortunately, as you can see, the femoral component is completely crushed. She had no fall. She just buckled and crushed her distal femur on her own, under her own weight. And that is what one is left with. It's like as if a bomb has gone off in the distal femur with no bone left there. And that is on exposure. Again, within 3 or 4 days, I was back on the same knee. And that is the kind of bone that is left behind. So here I have actually used, again, tried to use a femoral condyles to reconstruct and fully cemented the stems. As you can see here, 2 femoral heads I had used to reconstruct. I did not have, this was in fact done many years back, almost 15 years back. And we did not have anything else available to us. So only femoral heads were available, which were used. And the femoral stem was fully cemented, again, using a rotating, again, a constraint prosthesis here. And fully cemented stem has been used on the femoral side. And this is almost 4 years or 5 years down the line. Patient came for a follow-up, and there was flowing callus that had actually matured, and patient was able to weight bear and was actually walking on that. So let's consider what are the other options that one has for massive bone defects. The trabecular metal cones are actually considered bone substitution options rather than the implant component, because trabecular metals actually is a metal that actually encourages bone growth. This is a porous tantalum, basically. One has to know that this metal is porous tantalum, and the microscopic structure of this porous tantalum is similar to that of a cancerous bone. So bone actually grows within this porous tantalum, and therefore it can be considered as a bone substitution or a bone graft substitution option. And because the bone is actually going to ingrow within this trabecular metal. And you have various shapes of this trabecular metal that are available. Here is just one example of trabecular metal cone being used for the distal metaphyseal area. Similarly, you can see the cones that can be used on tibial side. There are various medullary cones that can be used as well. These are, diaphyseal cones that can come in various sizes and shapes. And similarly, large cones can be used for the metaphyseal area as well. These are the diaphyseal femoral cones that can be used on the femoral side. And similarly, metaphyseal femoral cones. So these are a variety of options that are available. Just show you some examples of using this cone. This patient came in with a periprosthetic fracture of the upper tibia. And this is on exposure and on removal while reconstructing. As you can see, big defect that is going to be left on the upper tibia. So I'm preparing for a diaphyseal cone here. This is the trial diaphyseal cone in place. And on top of that, I have got my LCCK trial component. And then I'm putting this final metaphyseal cone. Now, important to appreciate that this is actually has to be in contact with good host bone. And this has excellent scratch fit abilities. And once you actually impact it well in, it's difficult to dislodge that. And because you have good contact with the host bone, the host bone will actually grow within this trabecular metal surface. So you should not have any cement that goes between the trabecular metal and the host bone. That is a very important factor to consider, because that is how the trabecular metal cones work. Because it's a biological option that one is using. So this is the trabecular metal cone implanted in, and whatever gap there is between the host bone and the trabecular metal cone, I'm packing a cancerous bone that is available to me at the time. And then I put the trial component on, and this is the final way the tibia was reconstructed. It's important to have a cement layer outside the cone, because this exposed surface of the trabecular metal cone can be quite irritating to the soft tissues. And to prevent that, it was useful to have a layer of cement on the outer side. This is only cosmetic and functional use of that. And that is the post-operative X-ray of the same patient. And because it gives a good diaphyseal fixation for the prosthesis, it has to be considered as a bone substitution option, and it gives excellent scratch fit abilities. Another patient that came in for a second stage of infected revision, and this is on exposure after removal of the cement. You can see big defect on the tibial side, especially anteromedial side. And this is again using a tibial cone, a trial tibial cone in place, final tibial cone going in, and again impacted in place. And again, outer side is a thin layer of cement on the outer side of this outer surface of this cone. Again, the same principle and just the use of trabecular metal cone here. I'll just run through. There are quite similar examples. Again, massive metallosis because of the delayed revision surgery. However you clean, it does still remains black and still left with significant bone defect on the tibial side. A cone has been used here and a rotating hinge prosthesis used. Again, that's a post-operative X-ray. Here is a patient of supracondylar TY fracture femur with a pre-existing knee. Now, this fracture is so low that it cannot be fixed. One cannot expect any union. So I've used a TM cone to build up the distal femur. And on top of that, then I've used a revision component, and that is the post-operative X-ray of the same. This again worked beautifully because this TM cone really gets rigid hold within the canal. The last option, of course, for massive bone defects is a tumor prosthesis, where one is going to sacrifice the entire deficient bone in the distal femur and use a tumor prosthesis that is, the stem is fully cemented within the medullary canal. And this is the tumor prosthesis hinge that can be used. This is, I think I borrowed it from Dr. Pachore, this particular slide. So to summarize, I think pre-op planning is certainly vital. You really need to be prepared for various variety of situations. One has to expect a lot more bone loss than what you can see on an X-ray, especially in patient undergoing revision. A constraint process usually is required, and you can use it either with bone grafts or you can use it augments or extension rods. TM cones is an exciting prospect for bone loss if the allograft is not available. Thank you very much.
Thank you very much, Hemant. There are a few questions which have already come up in the chat box. The question is, in your revision unicompartmental case, can we use a sleeve and a stem instead of filling the defect medially?
See, sleeves can certainly be used. The problem is that this defect is actually medial. And if the bone between the medullary canal and the defect on the medial side, if there is a good bridge of bone, you would need to sacrifice that to get the sleeve in. Now, sleeve is also a good option, but sleeve is not considered as a bone substitution option. It is obviously an implant, giving a good stability within the medullary canal. I have not shown sleeve here because it is generally not considered as a bone substitution option. It can be used to get extra stability from within the canal, and sleeve can also be used. The aim is, I think, not to sacrifice more bone. So sleeve use in that particular case could have been tricky in the sense that you will have to sacrifice a lot more bone because except for the medial defect, rest of the bone is intact. And sleeve is not going to take care of only the medial defect. It's going to sacrifice some bone on the lateral side as well, which is entirely normal.
Yeah. And the other question is, in a failed uni case with a massive defect, what is your opinion on use of sleeve versus graft or an augment plus stem? Are we worried about the graft resorption in these cases?
See, if you have used a stem that is well fitting in the canal, then I think the graft will hold and graft will certainly consolidate. If the graft is getting loaded, right from day one, if the graft is being loaded and the femoral, the weight bearing, has to be taken away from the graft. And the stem actually does that job. Stem prevents the component from tilting, and the stem actually protects the graft and allows it to consolidate. So a stem, I think, plays a vital role in these situations. And in fact, what I have had to use augment along with the graft in that particular case. I've used augment as well as the graft because the inside of the bone that is available, I was left with even more defects. So I had to use augment as well.
Yeah. Dr. Raja?
I think if you have the availability of good structural graft, always restoring bone stock with bone is good. But in revisions, we always run short of grafts, and now we have moved on to metal augmentation and sleeve and cones. Probably if you have the graft available, then it's always good to use the graft wherever possible and support it with the stem extension.
Sure. Yeah, especially if the patient is younger and you expect that patient in his or her lifetime may require one more revision. So it's all the more reason for you to restore the bone stock.
Yeah. Any more questions, guys? Please.
So I have a question. When do you decide to move over from a cone to a tumor prosthesis type of construct?
See, frankly, the tumor prosthesis actually adds a significant cost. I mean, the cost becomes a primary factor in deciding the prosthesis many a times. The tumor prosthesis, to my knowledge, costs nothing less than 4 lakhs plus. I guess it's more in the tune of 5 lakhs. And cone, even if you use a cone with an RHK would cost maybe 3.5, something like that. So the cost becomes a significant issue when one is deciding. Obviously, tumor, some situations you can't use a TM cone. You can't really, you need to have some metaphysis available for you to put in a TM cone. If that is not available, the diaphyseal cone is not going to work in such scenarios. In fact, the case that I showed where it was a TY fracture, where I used a cone, that was a touch and go case where it might not have worked. I mean, I've got away with that, but it could well be that patient needed a tumor prosthesis rather than a cone.
I have a question, sir.
Yes, please. Hi, Leo.
Hi, sir. So, do you always pack bone grafts within your metaphyseal cones in the tibia, or do you pack them with cement as well?
No, in fact, that is an error to put cement, because if you understand how the cones work, cones are expecting the host bone to grow within. And, unfortunately, there's a bit of a history and a mistake on part of the company here. Now, Zimmer, when they introduced the TM cones, US FDA did not allow them to use as an uncemented usage right in the beginning. So early, the first user brochure that they came out with, they actually suggested that you put cement there between the host bone and the cone. And only when the US FDA gave their approval for the use of uncemented, then they rectified their mistake. So you're not supposed to have any cement going between the cone and the host bone, because that is not how the biology is going to work. That's not how it's supposed to work. You can have cement inside the cone, not on the outside where the host bone is in contact.
So on the inside, you do use cement there?
Inside has to be cemented. Of course, it has to be cemented.
You can't pack them with bone grafts?
No, it's not. That's not the way it works. Inside, it's not designed for a scratch fit like a sleeve is. So sleeve again works on a completely different principle. Sleeve, you can actually have a scratch fit or, it's like a, what do you call, taper fit. Whereas, the tibial component is going to have a taper fit within the sleeve. That is not how the cone is designed. Cone is designed for a cemented use inside. So no cement outside the cone in contact with the host bone, but inside it has to be cemented.
There's a lot of cement which is going to be there.
Yeah, exactly. And it is going to have excellent interdigitation because ultimately like a porous surface on the inside of the cone.
So when do you allow weight bearing after you use a cone?
No, if I'm happy with the scratch fit that I've got, then in fact I would allow immediate weight bearing. Only if even the hose bone is very poor and you're worried that even hose bone can crack under the weight, then one may decide to delay it and see how it is to be done.
So there's a question in the chat box. Do you perform pre-operative CT scan in all revision cases to assess bone defect and to decide your plan?
Frankly, no. I think you have to have go in with all your armamentarium. I don't routinely do unless I really am worried that it is how extensive it is. But otherwise, I don't routinely do the CT scan. Although CT scan, to be done is not a bad idea. But no, I don't do it routinely.
Yeah. Question: how are the results of posterior tibial defect?
Yeah, it worked well. The patient, it worked well. Yeah, again, the key is the stem. The key is really the stem.
Yeah. When you choose between a stem or a cone, either a cone or a sleeve, the decision, do you depend it upon the implant as well? I mean, the companies which make sleeves and the companies which make cones are different. So
yeah, they're completely different, and you cannot mix and match. You cannot use a sleeve of one company and an implant of another company. No, sleeve actually is a part of the prosthesis. Sleeve is not a bone substitution option. You could possibly do the other way around. You can use a cone and possibly use other prosthesis if it is going to fit in within the cone, but not with the sleeve. You can't use sleeve of one company and expect that some other company's prosthesis will fit in. No, because sleeve is not a bone substitution option. Cone is a bone substitution option.
So there's one more question now. Which stem you prefer, uncemented or cemented?
I said I prefer uncemented stem, and I do good metavascular cementing. I don't use a fully cemented stem if you can avoid it. The only situation where I will use a fully cemented stem is maybe a periprosthetic fracture when there is no metavascular bone, no good quality metavascular bone, or there are no collaterals and the soft tissues are extremely poor. In that situation, I will use a fully cemented stem.
I think the current understanding, it's better to use a short, stubby stem.
But short stubby has to be fully cemented. So it has to be good metavascular full cementation.
So would it be fair to say from taking on from the
Sorry, lost your audio, Leo. Lost your audio. Leo, we lost your audio.
Sorry, do you hear me now, sir?
Yeah, better now.
Yeah. So taking on from your answer regarding choice between cones and sleeves, would it be a fair argument to say that if you have a reasonably good bone stock, stick to sleeves, but if your bone stock is poor, you may have to consider cones?
Yeah, that's a fair argument because sleeve also would give an excellent fixation, but you need decent metavascular bone for that. Ultimately, it boils down to that. So, yeah, that's a fair comment.
So I think there are no further questions coming up on the chat box. So we need to thank Dr. Hemant Wakankar for sparing his time to give this excellent talk about management of defects, showing some complex cases. And we can then move on with Dr. Dhanashekhar Raja's talk. He is our colleague from Ganga Hospital in Coimbatore. Again, tremendous experience in hip and knee revision and primary arthroplasty. So he's going to talk about patellar resurfacing. And Dr. Wakankar, you are most welcome to stay, but depends on your commitments.
No problem. I'm okay.
Thank you. Generally, I resurface patellar, and this talk is more biased towards resurfacing. But I covered most of the relevant points about patellar resurfacing. So generally, we take a weight-bearing AP, lateral, and skyline view for any knee replacement patient, and we do assess the patellofemoral joint. Usually, we forget the patellofemoral joint many a times, and many of the patients come with without skyline view. So the controversy behind the patellar resurfacing, the whole orthopedic community is deeply divided, and there are equal number of studies favoring both techniques, resurfacing and non-resurfacing technique. Basically, there are 4 questions. The question number 1: can resurfacing improve patellofemoral performance and function? Example being stair climbing ability. Can it provide a reduction in incidence of anterior knee pain? Can it enhance patients' overall satisfaction, and is it cost effective? So there are 3 basic strategies: always to resurface, never to resurface, and selectively resurface. I started with never to resurface. Once we were using the PFC Sigma old PFC design, where there were a lot of patellofemoral problems. And then after my training with Ranavat, I went into fully resurfacing. I resurface every patella. Now I do selective resurfacing because the newer prosthetic designs are more patella friendly. So what are the pros of patellar resurfacing? Reduced incidence of postoperative anterior knee pain, avoidance of secondary resurfacing, high patient satisfaction, better overall function, low complication rate, and is relatively inexpensive and not time consuming. The cons for patellar resurfacing: there's a slightly increased risk of patellar fracture. The polyp also can get loosened, and there is a chance of avascular necrosis. And post-patellar resurfacing, PS type of, there is a chance of patellar clunk because of the formation of fibrous nodule on the superior aspect of the patella, then loosening of the patellar implant and instability. So pros for patellar retention: it reduces the operating time, preserves the host, reduces the chance of osteonecrosis, has more physiological kinematics, ability to withstand high patellofemoral forces without concern of and ease of resurfacing in case of recalcitrant anterior knee pain. So steps of patelloplasty. Either we do a patelloplasty, which involves removal of the osteophytes and then reshaping the patella to a more anatomical shape, because in osteoarthritis, the patellar shape is altered because of the osteophyte formation. And most of the time, all of us do this step. We remove all the osteophytes and try to reshape the osteophytes. Some of us do circumferential thermocoagulation. So this is called patelloplasty. We look at selective patellar resurfacing. We do it in age less than 65 years. No inflammatory arthritis. Retropatellar cartilage is reasonably well preserved. No significant anatomical abnormality in the patellofemoral joint, like good patellar femoral congruence, normal shaped patella, and adequate thickness. Normal patellar mechanics: the patella has to be tracking centrally, and patient does not have anterior knee pain. So this is an example of non-resurfacing of the patella at almost 10 years follow. Patient does not have any problems related to the patella. We look at the skyline view. You see the patella is congruently articulating in the femur. And some patients have severe tricompartmental arthritis with patellofemoral arthritic changes. As you can see in this patient, you can see there is a grade 4 changes in both the facet, medial and lateral facet of the patella. In these patients, resurfacing is a good option. So surgical principles of resurfacing: we need to restore the physiological patellofemoral spacing, the composite thickness. So we always, once we dislocate, we measure the thickness of the patella, and after resurfacing, we remeasure it so that we don't overstep the anterior compartment. Recreation of retropatellar high point through correct placement of the patellar implant. So we know the highest point of the patella. So your resurface implant should reproduce that high point. Restoration of patellofemoral relationship, that is joint level. Restoration of rotational alignment of femoral and tibial component. That's very important, because small rotation of the femur or tibia can change the patellofemoral kinematics, and balancing of the patellofemoral soft tissue, which I'll discuss in detail. So this is a video of patellar resurfacing. So I invert the patella in most of the situation for resurfacing, which makes resurfacing easier. You can do it without everting the patella also. There are jigs available for patellar resurfacing, but I use a freehand technique. I always follow Ranawat's technique. He removes the lateral facet. You know, the lateral facet is lower level. Once you remove the cartilage from the lateral facet, you can level the cut to the medial facet. So it most of the time restores the normal patellar thickness. So I'm just removing the lateral facet. Once you remove and you make it level with the medial facet. Usually the medial facet is slightly thicker. So once you expose the good cancellous bone, we assess the thickness of the patella. It should be equal medial and lateral facet thickness. I just feel with the thumb and make sure both facets are equal. And we put the patellar button and it has to sit in the center. So if the button is not fully covering, we need to move the patellar button slightly towards the medial facet so that the articulation will be the center. The center point will be corresponding to the center of the groove of the patellar, femoral trochlea. And placement of the jig also has to be perpendicular to the long axis of the patellar tendon. So once you invert the patella moves inwards and downwards and outwards. So you need to angulate the jig so that it's perpendicular to the patellar tendon. So when you reduce the patella, it will sit in the long axis of the femur. This is a 3-peg patella. It's an oval dome-shaped patella. This is a trial we are putting. We make sure it is completely seated on the patellar cut surface. And once you put back, you measure. Usually it's around 20 to 24 in most of the patient. So before cutting, if it is 22, we should reproduce to 22. So make sure that joint is restored. The amount of reduction should equal to what we are replacing. The patellar prosthesis itself is 6 mm thick. So we should avoid overstuffing by resecting less. Over resection also will lead to fracture of the patella. And we check the patellar tracking with the no-thumb technique. And this is an all poly component. We cement it along with the femoral and tibial component. So this is a tibial side cementing. This is a PFC sigma prosthesis. The posterior stabilized prosthesis, you can see the cam post mechanism. I use cement on both sides of the both implant side and the bone surface. Just pressurize it and remove the excess cement. Once the cement is set, we again check for tracking. It has to track in the center of the trochlear groove without lift off. So this is a technique for patellar resurfacing. So we should avoid internal rotation of the femoral component or the tibial component because it increases the Q angle. The Q angle is the angle formed between the patellar tendon and the quadriceps mechanism, patellar tendon and the quadriceps. So if you rotate the component, the Q angle is increased and it will lead to patellofemoral instability. So again, overstuffing or under resection should be avoided. The joint line also should be maintained. If you lower the joint line, again it leads to overstuffing. So we should recreate the physiological space to avoid a patellofemoral complication. Because if you are changing this patellofemoral dynamics, it increases the wear rate in the patellar prosthesis. So this is a knee society knee scoring system where they give the different angles to measure. So patellar width, patellar tilt, patellar thickness, prosthesis bone angle, prosthesis patellar displacement angle, medial and lateral. These are the angles we calculate. And coming to the different shapes of the patella, there are basically 3 types of patella. This is classified by Weberg. It's called Weberg's anatomical classification. It's a type 1, type 2, and type 3. Type 1 is roughly symmetrical facet. Both medial and lateral facet are symmetrical. Type 2 is a smaller medial facet and longer lateral facet. The type 3 is a very small medial facet and a majority of the patellar articulation on the lateral facet. So it's important to classify the patella pre-op so that your patellofemoral articulation can be understood. And once you resurface, this anatomy becomes important, because there is, when you place the patellar component centrally, there is medial lip top and you need to do a lateral release. So this is MRI classification. MRI images of the three types of patella. Type 1, where there is equal facet both sides. Type 2, where there is a smaller medial facet. Type 3 is a major lateral facet. Some other types like a cobblestone type also are present. So we analyzed our lateral release rates and factors which influence lateral release for our patients. 250 consecutive total knee arthroplasty patients were analyzed with the skyline view. We calculated the patellar tilt shift, patellar morphology, insult salvati ratio, tibiofemoral angle, and compared the incidence of lateral release and factors which influence lateral release. The major factors are patellar tilt and patellar shift. So the upper diagram A and B shows patellar tilt, and patellar shift is from the middle of the trochlear groove, how much it is shifted laterally. So these are two factors which influence the lateral release rate. If these two factors are present, then the lateral release rate is very high. So especially patellar Weiberg type 3 patella, there is higher lateral release rate. And with valgus deformity. With valgus deformity, we know there is lateral retinocular tightness, and many of these patients require lateral release. So if there is gross patellofemoral subluxation, it's better to go through a lateral approach, which will automatically release the lateral retinoculum, leading to a patellar tracking. So this is type 1 type of patella in a varus knee. You can see both facets are equal, and patella is tracking centrally. And if this patient have a good patellar cartilage on table and is tracking well, I don't resurface these type of patients with osteoarthritis of the knee. So here you can see type 2, which is most common type of patellar morphology. Many of our varus knees have this type of morphology. So if they have patellofemoral symptoms, I resurface in these patients. Type 3 is Weiberg type 3, where the lateral facet is a predominant articulating surface and it is slightly laterally articulating. We don't resurface, maybe we can get away without lateral release. But if you resurface these patients, definitely require a lateral release, because the patellar button is not going to sit on the center of the trochlear loop. You need to release the lateral retinoculum to bring the patellar articulation to the center. There are patients with isolated patellofemoral arthritis, like this patient. The tibiofemoral joint is normal, but you can see the lateral view of the patella, there is no cartilage. The skyline view will show the bone-on-bone articulation of the patellofemoral joint. These type of patients are very symptomatic. They are not able to climb stairs. They are not able to get up from the chair. They also require surgical intervention. Isolated patellofemoral joint replacement has being done, but I don't have the experience. So I generally do a total knee replacement for these patients, which has proven long-term effect. So next is the surgical technique to release the lateral retinoculum. Basically, there are two techniques: inside-out technique, where you do it through the joint, and this is the outside-in technique described by Rajesh Mania. So we divide the length of the lateral retinoculum into three parts: the infrapatellar area, lateral to the patella, and suprapatellar area. So minor mal tracking, we need to release only the infrapatellar area, which is called grade 1 release. Moderate mal tracking, it is grade 2 up to the middle third or proximal pole of the patella. So there's a total subluxation, then we need to do a complete release for the correcting mal tracking, as we see in this image. The advantage, your joint synovium is intact here, center star-shaped area, the synovium is intact, so the hematoma does not come out. If you do outside-in technique, the hematoma comes out through the synovium, through the retinoculum into the subcutaneous plane. So this is an example of type 2, I think, type 2, Weiberg type 2, if I remember. This is resurfacing and cementing done. So this is a patellar maltracking, this type 2. So you can see there is slipping off of the patella after tunicate release. The patellar tracking has to be checked after tunicate release. And this is outside in technique. We elevate the lateral flap below the deep fascia. You can see the patella is tilted laterally. Some amount of maltracking can be accepted, but such type of maltracking should not be accepted because once you suture it, there are a lot of forces across the polyethylene and there is increased wear rate. So this is the lateral retinoculum. One of the lateral retinocular vessels which is injured. We try to avoid injuring the vessels. There is a definitive vessel at the lower pole of patella, the one at the superior pole of patella. So if we increase each level of release, these vessels will get injured. So mostly I try, this inferior vessel always gets injured. We cannot avoid this. So this is retinoculum being released. I slowly progress to the superior pole. We make sure you don't injure the retinoculum. We avoid going to the superior pole where there is a more superior retinocular vessel. You can see there is slightly improvement in patellar tracking. That's not adequate. Still, it is lifting up. So going up to the superior pole now. Superior genicular artery is also has to be released. Usually there is a tight band below the vessel, so unless we release it, the tracking is not restored. You can see it's almost tracking. Now it is in contact with the medial facet as well. We generally use a couple of sutures and recheck the tracking. There's still some tightness on the lateral side, release it on table. The final tracking. So the patellar process are a different shape. I use a dome-shaped patellar, and there are now offset patella also available. Instead of shifting the patellar process immediately, we can put it in the center so that lateral uncoverage does not happen. All polypatellas are more successful. Metal back patellas are a catastrophic failure, which led to poor outcome of the unpopularity of the patellar resurfacing. So anterior knee pain post TKR, one of the most common cause of dissatisfaction. Does patellar resurfacing reduce anterior knee pain? It's still questionable. But we compare patellar resurfacing and non-resurfacing. There's one of the John Install Award paper. It says that there is no significant difference between these two groups regarding revision rate, knee society scoring system, both clinical and functional scoring, patient satisfaction, and anterior knee pain, and patellofemoral and radiological outcomes. But there is a small trend towards towards a non-resurfaced group. So, though it not reached statistical significance, this paper says non-resurfaced group is slightly better. Patellar resurfacing versus non-resurfacing meta-analysis. This includes 32 trials assessing 6,887 knees. There was a significant difference in terms of reoperation rate, knee society score, function score, and noise. A lot of these patients have patellofemoral crepitus. Non-resurfaced patients have patellofemoral crepitus. That is reduced after resurfacing. That is my experience. But some amount of fibrous tissue formation always happens, and even after resurfacing, a lot of patients complain of crepitus. So some noise is always present, but there is no significant difference when we compare the reoperation rate, anterior knee pain, function score, range of movements, Oxford score, or the KOS score. This is one more review article. The percentage of reoperation after non-resurfacing is around 1%, and they assessed a group of 1,636 patients in the patellar resurfacing group and 6.9% in the non-resurfacing group. Because there is anterior knee pain and patella is not resurfaced, there is a tendency to go back and resurface the patella. Probably that has increased the number of resurfacing, secondary resurfacing in this non-resurfaced group. So again, one more recent RCT, there was a statistically significant difference favoring the resurfaced group in the knee component and functional component of knee society scores. And there was increased risk of reoperation among knees which did not receive resurfacing. So my indication for resurfacing is PS knees except in type 1 patella with intact cartilage. Even in CR knees with patellofemoral arthritis, inflammatory arthritis are routinely resurfaced. Patient has primarily patellofemoral arthritis, and a patient generally has more stair climbing requirement. I preferably resurface in these patients. Thank you.
Shakhar, if I can ask you a question.
Yeah.
I'm sure Hemant would have a couple of words regarding resurfacing patella with a PFC component, CR with a CR box with a PS box in it.
Yeah.
There have been significant issues with the patellar clunk post resurfacing, especially with the PS implant in the PFC design because of the large box.
Yeah. Your voice is gone, Leo.
Why would you say that you would prefer to resurface if you're using a PS implant?
So all PS knees have this problem of patellofemoral plunk. So you need to decide whether you want to resurface or don't want to resurface. If you think resurfacing helps and you want to resurface, and you're using a PS type of implant, or already there's a deep box there. So sometimes I feel that patellar tracking is not great if you have a deep box. The PS design is not very patella friendly. I feel that if I'm using that PS design, I generally more in favor of resurfacing. After I do all the patelloplasty, do the simulation, and go back and recheck the patellar tracking after tunicate release, many times I'm not very happy with the patellar tracking, mainly because of the shape of the patella and the trochlear design. So one major problem with PFC is the deep box, which has the advantage of having the option to add stem even in a primary implant. So the advantage is not there. We have implants with additional stem options. But when PFC was introduced, the box was a big advantage because on a primary stem, you can add a primary knee, you can add a revision stem. Having a problem, you can add a stem. So it was an all-in-one option, but a big price to pay on the patellofemoral joint aspect. Good advancement at that time, but now I feel it's more of a problem of the patellofemoral joint. We have a good patellar prosthesis on top. The tracking is excellent, and we don't have much of patellofemoral crepitus.
So you think that even in the PFC PS design, having a patellar resurfacing helps rather than having it unresurfaced?
Yes.
The question is, Dr. Raja, is secondary resurfacing of patella. What is the role of secondary resurfacing and what are the results like?
First, we need to assess whether the anterior knee pain is primarily coming from the patella. You rule out infection. If any patient presenting with recalcitrant pain after TKR, you look at the joint properly, check for the joint stability, component placement, whether it's appropriately done. We can even do a CT scan to see the femoral component rotation. If everything is okay and your component is okay, we rule out infection and pain is coming from the patella, anterior aspect of the knee. more specifically from the patella, then we assume it is from the unresurfaced patella. So in those situations, patellar resurfacing has given good results. I myself have gone back and revised maybe a few patients, but the incidence is very, very low. As one of the paper quotes, it's around 6%, 6.9%. So the requirement for secondary resurfacing is very, very rare. And even if it is done in the correct indication, the results are excellent. The patients whom I resurfaced secondarily are all doing well.
Have you seen any evidence of patellar fracture or AVN following either replacement or lateral release?
AVN happens after TKR. It's primarily due to disruption of the blood supply to the patella. Whether it resurface or not resurface, there is a small incidence of AVN following TKR. Again, if you do a patellar resurfacing, probably it slightly increases the chance of AVN. Fractures due to AVN, I have seen quite a few, and it happens mostly due to AVN. It is atraumatic, just by muscular pull, it happens, and they do not heal. And most of the time we end up only repairing the retinoculum and preventing it from retinoculum we allow the retinoculum to heal, and AVN can be diagnosed only with a subsequent X-ray. The fracture happens with a minimal trauma. We diagnose probably suspect a AVN, but the AVN is revealed only after 2 or 3 months, where the fracture does not heal. The fracture site starts opening up, and you see the sclerosis of the patella. If you achieve the retinoculum healing by the time, we don't intervene. But even in spite of all these things, there is a AVN fracture destruction and patient having extensor lag. We go back again, feature the retinoculum again.
Another question is, we talked about it, I think, already, about the secondary resurfacing success rate.
What should
that question has been answered at the
minimum time. Yeah. So normal healing can happen up to 6 months or sometimes even up to 1 year. So before 1 year, I don't think going back or secondary resurfacing.
I think the time interval probably depends on whether the person goes back to the operating surgeon or somebody else.
Yeah, that is also.
What about your experience about doing an patellectomy after an AVN for these patients? How are the results, and how is the quadriceps function post-operatively?
I saw patellectomy when I was in Sydney. Patient with AVN with patellar fracture got distracted, so there was extensor lag. The surgeon went back and did a patellectomy and sutured the quadriceps tendon. I came back to India and then I called back the consultant. He said the patient fell down and ruptured the tendon. So it's not good. We try to keep the patella back, avoid patellectomy in a post-TKR patient. Even if the avascular doesn't matter, we just hold it there and then repair the retinoculum. Retinoculum does the most of the work. Non-union of the AVN patella. Patients with non-union, chronic non-unions of patella post-trauma, they are doing well. Maybe they have good extensor lag. But a lot of patients with non-union patella walking around doing most of the activities of daily living. So if you have a patella with AVN, better not to remove it, leave it there. Just repair the retinoculum, try to hold back the fragments with the tension band wire, and immobilize for at least 1 month to 6 weeks. That is here I see 1 or 2 patients with AVN in the last 10 to 15 years. We have seen quite a number of AVNs.
Any thoughts on why do you think patellectomy post-TKR is particularly poorer in results? Because in trauma, we do see quite a few patellectomies and they do quite well actually over a period of time. So any thoughts on why do you think in TKR patellectomy does particularly bad?
Because once we do a arthrotomy, the patella, do a TKR and put it back and resuture, there is a lot of fibrosis happening. Only with the suprapatellar pouch, and also the entire quadriceps mechanism is fibrosed. So you are taking a lot of revisions. It's not like a primary knee you open up. Post PPR, the knee is not like a normal knee. The flexibility is reduced. The entire quadriceps mechanism undergoes healing and fibrosis. Your range of movement is around 120. That's how you get out of a TKR. In these patients, if you go back and remove the patella, you're not able to approximate the tendon nicely. The elasticity of the tissues are lost, and it takes longer to heal, and the knee becomes stiffer. Unless you immobilize for a long time, like 6 weeks, it does not heal, and we start mobilizing early, the sutures will cut through. Because it's like a resurgery. It's not a primary patellectomy and repair. It is like a resurgery, and the results are not good.
Okay, I think excellent, Dr. Raja, and thanks for filling in at the last minute because of postponement of Dr. Vaidya's talk. I think we should thank Dr. Wakankar profusely, as well as Dr. Raja, for sparing time and delivering talks for the FNB students. Anything else, Dr. Wakankar, you want to add about the patellar resurfacing before we?
Well, actually, my views are a bit of opposite as to my practice is quite opposite to that what Dhanasekaran does, because I resurface my patella very, very infrequently. I would say less than 5%. And my impression, actually, I have not used PFC for almost 10, 15 years. And my problem with PFC was essentially with patellofemoral joint, and especially the crepitus and the clunks. These were the two major issues with the use of PFC. And in fact, the crepitus is quite disconcerting for the patient, especially it's much worse in PFC as compared to other PS for whatever reasons. And that is not necessarily to do with the box, but it is the anterior flange, which is actually quite wide for PFC, and it tends to overhang over the anterior cortex, because many times it actually overhangs significantly over the anterior side. And that is what causes where the retinoculum is going to slide over the overhanging, femoral component. That is what causes the crepitus. And that is quite painful at times. And in fact, there was time when I used to resurface patella, but I did find incidence of anterior patellofemoral pain, even with resurfacing. And that was, I think, almost 15 years back I'm talking about. And that was a time when these patella-friendly prostheses came into market. And what I mean by patella-friendly is the kind of prostheses like NextGen, which actually was, not overhanging anteriorly as much, and the box was actually far better designed. See, remember, PFC has stood the test of time. I mean, PFC is probably one of the longest serving prostheses next to IB2. I think probably more than IB2 now, because it's designed 35 years, 40 years back, something like that. So PFC has has had its glory days and share. But today there are far more, far better designs available. So in today's day and age, I think one can look at prostheses that are patella friendly. No question about it.
Yeah.
So you do resurface PS knees or CR knees, sir? Do you see any difference?
No, I use PS knee, and frankly, with NextGen in last 20 years, I have seen maybe one patella clunk or two, if at all. And I'm talking about 15,000. So that's what I'm talking about.
I think most of the knees, as Dr. Wakankar has said, now have converged their design to resemble what is like the NextGen groove. And if you see, even the new Attune will be much similar to what the NextGen is now. So
what personalized today? Personalized today?
Yeah, so every company has narrowed down their trochlear design quite significantly to a similar design. So I think that issue now hopefully is pretty much taken care of. And I, like Dr. Wakankar, we haven't been replacing patella at all. Very rarely, very, very rare. So I think thank you very much. And on that note, we should call it the end for today's teaching session. And We'll catch up next Wednesday.
Lovely. Thank you very much. Thanks.
Thank you, Dr. Hemant.
Thanks, Dr. Raj.
Thank you. Thank you.
Bye.
2.3.